عليك. شكرا.
So thank you for inviting me. I'm Ahmed Magdy. I'm a lecturer of medical oncology in the National Cancer Institute. I promise no mumbo jumbo over my chemotherapy, so I'll go straight. So we have to know the magnitude what we have. So for the cancer pancreas, the incidence all over the world, based on the GloboCan axis, that pancreas is not that prevalent. This is the first thing. However, by lethality, it's still not even in the top 5 or 7 actually. So why are we talking about cancer pancreas? So if you look on the distribution according to the regions, you will find that China, United States, and Japan are the most, have the highest incidence, while if you go down, you won't find it in our countries. Then why are we talking about it? So it's the 5th cause of mortality in the US, and by 2030, it's expected to be the number 2 killer or cancer-related mortality after lung cancer. So we have to know that lung cancer will ever remain the number 1 killer in cancer. And only 15 to 20% are diagnosed as resectable and not early, okay? And 70% of our patients are late in their presentation, whether they are locally advanced or they are metastatic. 5-year survival, even after surgery, it's only 3 to 15%. So we are dealing with a highly lethal malignancy. And the factors contributing to the poor survival is late stage at presentation, incurable stage are almost 85%, which correlates with the 15% I told you about. And the tumor, unfortunately, is chemoresistant. So with all the advances, with all the immunotherapy, with all the targeted therapy, still cancer pancreas, our hands are tied. So why screening? The problem with screening in cancer pancreas, it's the low disease prevalence, as I showed you, and the existing diagnostic methods will lead to a lot of false positive findings. And screening should be targeted to the high-risk individuals. So who are the high-risk individuals that we're talking about? Individuals in families with inherited risk, cystic lesions of the pancreas, and more than 50 years with a newly diagnosed type 2 diabetes mellitus, and we need to stress on that, and I will get there. So for individuals with inherited risk, there is the HBOC, which is the hereditary breast ovarian cancer syndrome. This includes the BRCA1 and the BRCA2, and as you can see here, the pancreatic cancer is only from 0.5 to 7%. So this is one of the syndromes. This is the other, the Lynch type 2, hereditary non-polyposis colorectal cancer. And as you can see, of course, colorectal will be number 1, but also it has an incidence of cancer pancreas. What about the Peutz-Jeghers? Yes, Peutz-Jeghers 2 has an incidence of pancreatic cancer. Li-Fraumeni is our famous syndrome in malignancy. I've seen many patients with 2 and up to 3 malignancies at the same time. Cystic lesions of the pancreas, it was discovered and it was published in the Lancet Gastroenterology and Hepatology in 2021 that pancreatic cysts are found in approximately 8% of individuals older than 70. And specifically, we have to look at the intraductal papillary mucinous neoplasms and mucinous cystic neoplasms. Both of them have a higher risk of transforming into pancreatic adenocarcinoma. What about type 2? So people with long-standing type 2 diabetes, which is long-standing here refers to more than 5 years, has only 1 to 1.5 folds higher risk. While type 2 diabetes for less than 1 year, the relative risk is 5.4 fold. So basically, we have to turn our radar on when we are seeing a patient over 50 with type 2 diabetes mellitus. We think that we should start the screening, but do we have guidelines for screening? Let's see. So recommendations for screening. So the US Preventive Task Force and many of our guidelines actually recommend against screening for asymptomatic adults at average risk. So we cannot do it on mass of individuals or asymptomatic. Also, screening of the general population carries risk and no evidence that it reduces mortality or even if cost effective. And the recommendations they published was around the 5% that have the high risk. And to tell you the truth, this is the same problem that we are facing with lung cancer. Even if they're screening for lung cancer, we failed. So we need to screen 330 individuals at high risk to only catch one and save one patient. And for the prostate cancer, it's 1 for 32. So we need to work more. So what are the recommendations for the high risk? At least two first-degree relatives with history of pancreatic ductal adenocarcinoma, hereditary pancreatitis, or the genetic syndromes that we mentioned, mucinous cystic lesions of the pancreas, and if you find it by incident, like the incidentalomas, so please follow them more closely. New onset diabetes, as we mentioned before, the modifiable only risk factors, as been mentioned by our speakers, smoking, obesity, and then you do have the age, which is non-modifiable, specific comorbidities, and early symptoms. The issue with cancer is we have no specific symptoms for malignancy. That's a huge problem. So for a successful screening, it should be improve the patient's survival without only increasing the time between diagnosis or the lead time bias. The lead time bias is super important here, because if you do the screening and you will not differ in your control of the patient or the overall survival, then this is a failed screening protocol. So it aims to detect and treat, as you can see here, T1 lesions, which is super early lesions. We've never seen in my practice, I've never seen a T1 lesion. So the recommendations is only cross-sectional imaging and blood tests. So cross-sectional imaging like the MRI or endoscopic ultrasound, and tumor markers with the CA19-9. And please bear in mind that CA19-9 is not specific for cancer pancreas. So I cannot depend solely on just an elevated CA19-9. Cystic lesions, if you find cystic lesions, please intervene with surgical intervention. Then you do a follow-up with the cross-section, as I mentioned, the MRI and endoscopic ultrasound every 6 months for the first year, and then annually thereafter. And thank you so much for listening.